Congratulations to all the interns. You finished your first month. That's wonderful. It's only going to get easier. So the first month, you'll just be amazed how much you'll learn this year. It's amazing what the learning curve is as an intern. And then you get to be residents, and then it's all old hat, right? My name is Bill Leland. I'm with the GI department. If you guys we're here to help you. If you have any questions, you need help with anything, just pick up the phone and give us a call or send an email. We'll try and help you out with it. My talk today is, I'm going to tell you how I approach liver disease, how I approach working up liver disease. I have 4 questions that I ask the liver, and I'm going to tell you what those are. Those are the 4 things I hope you'll remember. Anybody else talk to the liver? Am I the only one? Anybody talk to themselves? Not good? Well, I'm going to talk to you, and then this is the liver. It's right upper quadrant. It's one of our the biggest organs that we have. How many lobes in the liver? 3 lobes, right? Right lobe is the largest. Each of these lobes are divided into segments. Left lobe, and then what's the third one? The caudate, right? It's behind these 2. It's important to know the vascular supply to the liver. It's what are the 2 vessels that supply blood to the liver? Portal vein. Portal vein is high in what? It's high in. Where does the portal vein come from? It comes out of the intestine, right? Your portal veins right now are high in what? Yeah, high in nutrition, high in glucose and other things. It's absorbing food. But it's low in what? Oxygen. The hepatic artery is just the opposite. It's high in oxygen, low in nutrition. 2/3 of the blood to the liver comes through the portal vein. About a third comes from the hepatic artery, but the hepatic artery supplies way over about 60% of the oxygen to the liver. So you can compromise the portal vein, but it's not going to compromise the oxygen supply to the liver. You compromise the hepatic artery, and that will. Okay, now here's my first question. How many organs are in the liver? How many? Some of you know this because I think I might have told you last year. But when you think of the liver, how many organs do you think of? 2. Okay, everybody say 2. 2. The liver's 2 organs, all right? The liver is a biliary system right here, and it's a hepatocyte system. The liver is 2 organs that are intricately interwoven, intertwined. This is a macroscopic view. This is the microscopic. This is the basic functioning unit of the liver right here, shaped somewhat in a pentagon type fashion. In the middle is the central vein, and on the outside over the 5 little points we have the portal triads, which are composed of hepatic artery, portal vein, and a bile duct, right? So, and the blood flows which way? Does it go that way towards the central vein or away from it? It goes towards the central vein and it drains out right and towards the vena cava, and bile flow is in exactly the opposite. The bile flows in the opposite direction. It flows this way. This is even a closer up look of, and once again you can see how the biliary and the hepatocyte system are intricately intertwined. Okay, so point number 1 is the liver is 2 organs. Now here's my roadmap. And this is all this is the least I want you to remember. Is the 4 questions that I asked the liver. The first question is, hello, are you the liver? Hello. And so the second question is, are you injured? The third question, are you damaged? And the 4th question, what's causing your problem? Those are the 4 questions, and I bet you can remember those. And let's go through them. So, question number 1, hello, are you the liver? So you'll call me up and say, help me with a patient who has elevated transaminases. And we found this guy. He may or may not have been an alcoholic. He's been laying on the floor for 2 days. I'll say, hello, is this the liver? Because you're thinking that what's the CPK? Okay, you're thinking maybe it's not liver problem, maybe it's rhabdomyolysis. So, hello, is this the liver? Remember, there's also some autoimmune disorders like thyroid, celiac, and adrenal insufficiencies that can cause elevated transaminases. You know that an phos elevation, hello, is that always the liver? Not always, right? And what about jaundice? Is jaundice always the liver? Hello, no, it can be hemolysis. So first question, hello, is this the liver? And False positive, many times, this was from 2008, there's baseline fluctuations, and so you might just have a lab value error. So question number 1, hello, is this the liver? Number 2, okay, injury. How do you measure injury in the heart? What do you do to measure heart injury? What's blood do you draw? CPMB, what else? Troponin. The liver injury blood test. Okay, if it's a hepatocyte injury, it's the AST-ALT. That's a measure of injury. And if you're worried about the other organ in the liver, which is the bile, that liver injury is measured through the ALT phos. So, hepatocyte and biliary. Hepatocyte injury is known as hepatitis. Biliary injury is cholestasis. So, your second question is, are you injured? Which organ, bile or liver, hepatocyte, and you can tell based on whether the AST-ALT are elevated or whether the ALT phos is elevated. All right? Now, question 2A, this is a little bit of an aside, but it has to do with the severity and the chronicity. And so you're also thinking which organ, but you're thinking how bad. How bad are you injured? And usually in the hepatocyte side, if the AST is less than 2 to 3 times normal, and there's no other systemic problems, like they're thinking clearly and their kidney function is good, and they're ambulatory, walking, they don't have a fever or anything, well then your hepatocytes are injured, but not very severely. Chronicity can be, and is often very important to determine, and is usually based on previous blood tests. You can ask them questions like, have you ever donated blood? Was your blood accepted or rejected? That can give you an idea of how long the injury pattern has been present. On the biliary side, milder injury usually is without any pain. They're afebrile, they don't have a fever. Again, there's no systemic signs, and their bilirubin is normal. Any questions? At any point you have a question, please raise your hand. I'll be glad to help out. So, 1, hello, is this a liver? 2, who's injured? Where's the injury? Hepatocyte, biliary. 2A, how long, how bad? Now, damage. This is one of the more important points, distinguishing between injury and damage. So how do you distinguish between injury and damage in the heart? Troponin is a measure of injury. Does that tell you whether the heart's damaged? It doesn't, right? What do you do to measure heart damage? You get an echocardiogram and do a cath, stuff like that. Same with the liver. We use the AST-ALT and the ALT phos for injury. For damage, completely different type of labs. So for hepatocyte injury, the most important is the INR, and then albumin and bilirubin. What are the 3 components actually of the MELD score? INR, bilirubin, and creatinine. So that's a measure of hepatic damage. And notice that the ALT and the AST, are they included or not included? They're not included. The AST and ALT are not a way for you to tell whether the liver is damaged. And platelet count, thrombocytopenia is many times only is an early presentation or a presentation of cirrhosis. Renal function, and of course, I think you're all familiar with the physical stigmata of liver disease. So when I'm reading your H&Ps, I'm going to be looking for this. I'm going to be looking for, you're consulting me for abnormal liver tests. I'm going to be looking to see if you have checked for the physical stigmata of chronic liver disease. Your notes need to say there were no telangiectasias. There's no spiders, there's no palmarothema, no gynecomastia, no evidence of ascites, etc. And then what about on the biliary side? Evidence of damage. Damage on the biliary side is a little bit harder, but if the duct size is normal and the bilirubin is normal, and there's no complication of the hepatocyte side from biliary damage, then that's usually an evidence that the biliary system is functioning normally and it's not a problem. So 1, hello, is this the liver? 2, which organ are you injured? How long and how bad? And number 3, the damage. Or do you have any damage? And corollary on damage is compensated or decompensated. In other words, how bad is the damage? And in somebody that you're following with chronic liver disease, this is going to be an ongoing assessment. You want to be able to see if their liver is able to maintain itself, maintain the organism's function without encephalopathy, without ascites, without any evidence of varices. And then the fourth thing would be hepatocellular CA. That's another complication of chronic liver disease. On the biliary side, typically if the bile duct's not working, it's dilated, you can get cholangitis, and then the biliary system washes over into the hepatocyte side, and you have a hepatocyte, or that side would be malfunction. So, 1, hello, 2, injury, which organ, 3, damage. Got it? Now, what about etiology? Let's ask here's a question for y'all. Here's a 42-year-old man. He's put in the hospital with chest pain, and astutely you notice that his transaminases are elevated. He has no past medical history, and his hepatic function is normal. And so, which of the following do you think is a good answer? Do you recommend at this point complete viral hepatitis panel, Hep C, PCR, and genotyping, alpha-1, ANA, AMA, iron, TIBC, ferritin, cereals, platinum, CEA, CA19-9? Who likes that shotgun? All right, like, I see this, and so I appreciate your guys' ability to distinguish these and make some more efficient and cost-effective decisions in working on the liver. Do we want a viral hepatitis panel, CT, abnl, blah, 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 MRI, CP, blah, blah, blah? Anyway, my point being, let's not shotgun liver disease. Let's try and determine what we think we need to do and why. So the most important thing is history taking. And y'all are aware of the pre-test probability. It determines what kind of test we want to order. And what are the top 10 questions to ask patients with liver disease? Or that you're working at the liver? What are the top 10 what?
Medications.
All right, number 1, medication. What's the second one?
Alcohol. Medication.
Medication, good. And the third one? Medication. Get it in your head that most people you see, the medication is the problem. And you have to ask these patients 10 different ways. Seriously. I'll ask a patient, are you taking your pills? They'll say no. And I'll say, do you take any medication? They'll say, absolutely. And they'll tell me. Are you taking your friend's medicine? Are you taking your mother's pills? Are you taking over-the-counter medicine? Did you mail order any medicine? Keep asking because you know they're taking medicine that's causing the liver problems, okay? And when you've exhausted yourself, and you've exhausted the patient, and you've exhausted the family, then continue with your history taking. And ask them the other questions. Have they been exposed to blood products? Do they share needles, tattoos? Do they have any family members that have been diagnosed with hepatitis? And sexual history. You also want to ask about family history. There's 3 genetic or metabolic causes of chronic liver disease or elevated liver tests. And then, if you haven't done it already, assess for chronicity. Assess for, have you ever been turned down for a life insurance physical? Try and find some older liver tests if you can. And then, non-invasive diagnosis. We can figure out almost every liver problem without a liver biopsy. So if you have a question on your boards, what is the next best step, and it says liver biopsy, that is probably the wrong answer. Okay? It's probably something else. Now, also in your history taking and physical exam, you're going to be looking for the stigmata of liver disease. And in terms of what we talked about before, chronic injury, chronic mild injury over time can lead to cirrhosis. And then the labs. What are the labs that we want as we're assessing somebody with liver injury? What's that? INR. What else? Albumin, Bili, and the other one? Platelets. Okay, so you've got that in your head, right? The difference between function and injury. Function and injury. That's what I'm pointing out here again. All right, here's the first case. This is a 55-year-old admitted with a 3-week history of jaundice. He has a long history of alcohol abuse. Stopped 2 weeks ago. His family report mental status changes. On exam, he's confused. His heart rate is elevated. His ultrasound shows ascites. No other problems. No ductal abnl, no liver mass. White count is elevated. Bili's 30. AST and ALT 108 and 40. Phos 77. Albumin 2. INR 4. Creatinine 1.9. First question. Hello. Is this the liver? What do you think? Most likely, okay? Yeah, this is a liver. Question 2, what's injured? The hepatocyte, or the bile duct system? Hepatocytic. So this is a hepatocyte problem. So already you know, I'm not too worried about the biliary system. Why? Because the out phos is normal. There is no injury going on the biliary side. So I don't need you asking if he needs an MRCP for his jaundice, right? His jaundice is not related to a biliary problem. We don't need an MRI cholangiogram. We need to start looking at reasons for hepatic problems. All right, second question, how bad is the injury? Is this guy sick or not very sick? All right, so white count's elevated, INR is 4, creatinine is elevated. He's sick. We don't know though, we don't have a history of him. We don't know if this is an acute problem or acute on chronic, okay? If this was a chronic alcoholic that has been in the hospital multiple times, his MELD score is terrible, this guy would be getting close to the end of his abilities to sustain life. So we don't know if this is an acute or acute on chronic problem.
Can I ask you a question?
Yeah.
If you have an acute problem, would INR be that bad? I was just wondering.
Absolutely. You can have an acute hepatic injury from hepatitis B or C, and that's called fulminant hepatic failure. So
INR like an indication for acute or
it can be both. So the INR is a measure of injury and how bad, or it's a measure of damage. So acute injury can cause damage, just like a little bit of injury over time can cause damage. So it helps us with both. And if this patient, well, you know, had been completely normal, he went and got his life insurance exam, you know, a month ago and had completely normal tests, this guy would be an acute hepatic failure, basically. He's got mental status changes and his INR's up.
Leland, what is the first biochemical marker for hepatic injury? Is it INR?
INR. In terms of like severity of injury, yeah. Your INR is what you need. Yeah, that's what I want you to follow. And so if you're seeing a patient with an ALT of 1,400,000, is that a number? If you're seeing somebody with an ALT that's super elevated, what do I want you to see every day? An INR. I don't really care what the ALT is the next day. I really don't. I want to know if they're thinking, and I want to know if their INR is normal. Okay? ALT is a measure of injury. It's not a measure of function. When do we transplant? We transplant when their function is so bad that they can't be saved. So an ALT could be going down every day. You're taking a good ALT every day, and the INR is not on the chart for a week. The ALT going down, does that mean they're getting better? Absolutely not. It could just mean their liver's just dying, and they're not making ALT anymore. And their INR is 7, okay? So the INR is what I want to see. All right, so what's the most appropriate management for this patient? Ceftriaxone, you might want to put him on antibiotics, methylprednisolone, FFP, liver transplant, or antibiotics and prednisone. What do you think he has? He's got, what's that? He probably has severe alcoholic hepatitis, right? Based on your options, that's your best bet. Why did they order an ultrasound? Did they order the ultrasound to look at the ducts? No, they looked at the ultrasound to assess for hepatic damage. Maybe he's got a liver mass, maybe he's got ascites. If you got ascites with that kind of white count, what would you need to do? Yeah, he needs to be tapped, all right? And so no ascites, this guy needs methylprednisolone. His MADRI score is probably over 30 or whatever the cutoff is. And prednisolone, not prednisone, can improve their life expectancy, and that's what you'd want to do. He's not a candidate for liver transplant. Why? Yeah, he's been drinking up until 2 weeks ago. All right, let's do this one. Here's a 25-year-old male is evaluated after being turned down for life insurance due to the abnormal liver test. His social history is negative, review assistance negative, physical exam is negative. His AST is 35, ALT is elevated 68, phos is elevated, bili's normal, and he's got hemoglobin 12 with an MCV of 76. First question, hello, is this the liver? Anybody want to say, yeah, this is absolutely liver? Well, in this case, I'm not sure. I'm not sure if this is the liver. Everything else is normal. His history is negative. And so what you have to do is you have to march down the pathways until the end, and then you come back. So I would go to the hepatocyte and say, I'm not sure his ALT is 68. If it is hepatocyte, is he sick or not sick? He's not very sick, so it's very mild. And do we think, has this been going on for a while? Probably not. I mean, his physical exam is all normal. And then you go to the next step, is there any damage? No, there's no damage. Then you go to the end of the line there and go, man, on my history taking, I don't see any reason for you to have hepatocyte problems. None. All right? So then you go back to the beginning, you go down the cholestatic line. His phos is 179. He has no pain. His bilirubin is normal. I don't know if there's any hepatocyte, any biliary problem here or not. So you come all the way back to the end. And then you ask yourself, what would be the most appropriate diagnostic test? Anti-tissue T-glutamase antibody, alpha-1 antitrypsin, blood alcohol, liver biopsy, repeat blood test. Which one do you know absolutely for sure not to do? Right. Okay, thank you. Good. All right. What about repeating his blood test? Yeah, that's a great idea, and I would absolutely recommend that. And that's probably what I would do next, except he's got an anemia. Here's a 25-year-old with a microcytic anemia. So, hello, is this a liver? Maybe not. Maybe he's got celiac disease. That will cause elevated liver tests and microcytic anemia in a young person. So, your best answer here, because of the anemia on this question, is to get the celiac workup. So, hello, is this the liver, injury, damage, and etiology? Let's go through some of the etiologies. What's the most important? Medication. After you've exhausted yourself, then realize that about 10% of the cases with medication related are going to be over-the-counter medicine or herbal kind of stuff that they're not going to tell you about. Prescription medication, especially antibiotics like Albumin, that's real common. Of course, acetaminophen. But ask them about their medication. Alcohol injury. The AST to ALT ratio is really important. So the AST is it mitochondrial or cytoplasmic? It's mitochondrial. The ALT is in the cytoplasm. So there are specific injuries to the mitochondria, and alcohol is one of them. So the AST is going to be higher than the ALT. And they did this study where they did liver biopsies on everybody and compared it to their ratios. And when their ratio was greater than 3:1, then that was a 96% diagnostic for alcoholic liver disease. Okay? So look at the ratios, AST, ALT. In the first patient, the AST to ALT ratio, do you remember that? The AST was higher than the ALT. AST to ALT is also a measure of cirrhosis. And then the caveat is that if the AST is greater than 5 times normal, it's probably not liver, it's probably rhabdomyolysis or something, especially if the ALT is normal. So that's just a little tip for you. 3:1, 4:1, higher than that, think something else, but if the AST is higher than the ALT, that's probably alcohol-related disease. Hepatitis B and C, the history there is going to be parental exposures in endemic area if they're from the Far East, or if their mother had hepatitis B, that kind of thing. What about, okay, let's do this case. Here's a 53-year-old male with a history of diabetes and MI, presents for evaluation of abnormal liver test. The patient's obese, there's no evidence of chronic liver disease, ALT is elevated, AST is elevated, phos is normal, Bili is normal, albumin is a little bit low, INR is normal. So, hello, is this the liver? Could be, right? I don't know, but probably, maybe, we'll see. Yeah, maybe. How about that? Is it biliary or is it hepatocyte? Does he have cholestasis or hepatitis? It's hepatitis if it is the liver, right? Because AST and LFT. Is this guy sick or not very sick? No, not very sick. And then is it damage or no damage? No damage. No damage. INR is normal, albumin is normal. Albumin's a little bit low. So maybe that could be related to the liver, but he's got other chronic medical problems, so you'd have to sort that out.
Can you say that? I mean, there could be minor damage because could there be some reserve function that INR is still normal? You know what I mean?
There could be some mild damage, but for our clinical purposes,
Okay.
short of a liver biopsy, unless there's physical exam findings or you have an abnormal bili, INR, platelet count, or albumin, then for all our purposes, they don't have evidence of liver damage, okay? And so I would say no evidence of chronic liver disease in that case. I wouldn't do a liver biopsy. If they're being imaged for some reason, then sometimes we do see on CAT scan a nodular liver with a normal INR, normal bili, normal platelets, and then you might say evidence of chronic liver disease on CT, but not confirmed on any other value. Okay, what's this person have? What's your best guess? Hepatitis is a possibility. What else? All right, so NASH. Thank you. This guy's obese. He's got diabetes. He's had an MI. You got to please think NASH, non-alcoholic steatohepatitis. The most likely diagnosis is steatohepatitis in that patient. Why is it not hepatitis A? What's that? Doesn't cause chronic doesn't cause AST elevations like that. It's more acute. And then autoimmune hepatitis, more common in females, and the globulins usually, I'll go through that. And then Wilson's disease, not Wilson's disease, okay? So just a quick aside, maybe y'all will invite me back sometime to talk about these causes of liver disease in more detail. But I do want to get in a plug for fatty liver and remind y'all to look for that in your clinics and remind you to evaluate people with fatty liver for chronic liver disease. Those who have evidence of chronic liver disease, we need to see them, okay? So keep an eye out. You're going to see a lot of patients with metabolic syndrome who probably have chronic liver disease, and it's from steatohepatitis. How many people in this room have fatty liver? How many of y'all have fatty liver? All right, this is a trick question. Everybody raise your hand. All right, here's the corollary for that. How many of y'all have gastroesophageal reflux? Everybody raise your hand. Reflux is a natural process in our body. We all have it. When the reflux gets over a certain amount of time, the amount of acid in our stomach exceeds 5%, over blah, 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 there's all these things, then you have gastroesophageal reflux disease. You start having symptoms, GERD, okay? Everybody has GERD, but not all of us have GERD. Everybody in this room has fatty liver. How many of y'all have fatty liver disease? I don't want you to raise your hand. Most of you don't have fatty liver disease. And it's based on how much fat you have in your liver. So less than 5% fat intrahepatically, inside the hepatocytes, that's normal. When it gets over that 5% range, you can start picking it up on imaging studies, and that's called fatty liver disease. Fatty liver disease is a spectrum, just like gastroesophageal reflux is a spectrum. So people have GERD, and then some people have GERD with Barrett's, and then some people have GERD with Schottky's ring, and some people have GERD with cancer. And so the same with fatty liver, it's a spectrum. Some people just have simple steatosis, they have fat in their liver, but nothing else. Some people have fat and inflammation. Some have inflammation, fat, and fibrosis, and then some have cirrhosis. And this is the way it looks like. Here's fat in the liver. See the little fat droplets? Here's fat with inflammation, all these little small little dots are inflammation. And here's nodularity with fatty liver-related cirrhosis. And so that's the spectrum, and it's becoming the most common cause of liver disease, short of medicines, short of medications in Western countries, and it's associated with metabolic syndrome. You're going to see a lot of patients like that in your clinics. All right, we're moving on. Autoimmune hepatitis, you're going to see it. It's not rare. It's typically in females more than males, and the liver test can be very, very elevated. Patients with autoimmune hepatitis, their ALT may be 1,500, and so think autoimmune hepatitis, particularly if there's a high gamma globulin, if there's a big difference between the total protein and the albumin. And we diagnose it with ANA, ASMA in the right setting and treat them with steroids. Wilson's disease, this is rare. Rare, okay? Is it in young people or old people? Young people. Don't order ceruloplasmin in a 65-year-old man. It doesn't happen, okay? It's another, he's got something else. He doesn't have Wilson's disease. It's in young people. Board question, what causes hemolytic anemia and liver failure? What causes hemolytic anemia and liver failure? That's your board question. It's a class. It's a presentation that they'll ask you about. A young person comes in with acute liver failure. Their ALT phos may be low, and they've got hemolytic anemia. That's Wilson's disease until proven otherwise. And you diagnose it by a serum ceruloplasmin or 24-hour urine copper. Remember, all these metabolic diseases, are they liver or are they systemic? They're systemic diseases, right? They're genetic metabolic problems. So the Wilson's people, they get what else? They get neuropsychiatric problems. They get, what do they get in their eyes? Kaiser-Fleischer rings. And so in all these, we look for systemic problems. Low ALT phos, hemolytic anemia. Hemochromatosis, this is a white person's problem. It's in the Caucasian populations, Northern European descent. Do not order iron studies and genetic testing in a 72-year-old black man. It doesn't happen. He does not have hemochromatosis, okay? And but these are the genes that have C2A2Y. People that are homozygote for C2A2Y have hemochromatosis. You want to see if their ferritin is usually over 1,000 and their iron saturations are greater than 45%. Alpha-1 antitrypsin can be associated with lung disease, and the key is a ZZ allele. Some patients with MZ. Is there a difference in the lung disease and the liver disease in alpha-1? There's a difference, and what is it? What does alpha-1 antitrypsin do? Antitrypsin. What does trypsin do? It's like a Pac-Man. Trypsin, right? It eats things. It comes out of your pancreas and other places. And so antitrypsin. Yeah, there's neutrophil elastase and so this counteracts proteolytic enzymes. And so what it does in the lung is it keeps the proteolytic enzymes from digesting the lung. The liver's different. And what's that?
The liver, and then if they're abnormal, they can excrete.
And the liver, right, the liver packages these guys, and it can't get it out of the mitochondria. And so that's why there's a treatment for alpha-1 antitrypsin deficiency in the lung, but there's no treatment for it in the liver. There's untreatable. You can only transplant them, that's right, because it's a packaging problem, it's a storage problem. All right, summary, medication, medication, medication. Alcohol, viral, fatty, autoimmune, and metabolic disorders. All right, and then there's a separate category. You know, people who come in with very bad injury, very bad, severe hepatocyte injury. You think of toxins, think of medications specifically, Tylenol, acetaminophen, shock liver, what's that? Shock liver, viral B and A, very rarely C, but it can happen in autoimmune hepatitis. What do you do when somebody has acute hepatic injury, bad injury? In other words, their AST is 15,000. It's not going to get that high, but their AST is 1,400. We want to monitor for liver failure, and so I'm just going over this again. But when you consult me on somebody with an ALT of 14,000, then what you're monitoring, what you've written for is, 3 times a day neuro checks. You've written for AccuChecks 4 times a day. You've written for an INR at least daily. That's the way you're going to tell if they're fulminant. In other words, once their mental status changes, if their INR goes out 3 or 4 times normal, they need to be in a transplant setting. They don't need to be here anymore. But that's what you have to keep up with. And then again, just to reemphasize, ALT and AST are a measure of injury. You can sometimes have marked injury, but no damage. You got to keep up with the damage using those other values that I've already talked to you about. Here's a 21-year-old woman who was evaluated for a 2-week history of nausea and vomiting and new onset jaundice, no associated abdominal pain. White count 7, Bili's 12, AST, ALT 35 and 60, alk phos is 480. Question 1 is, hello, is this the liver? What do you think? I would say, yeah, it's the liver because the biology, Bili's up and the alk phos is up. Isolated alk phos, normal AST, ALT, normal Bili. Isolated elevated alk phos, what would be your next step? GGT. Next step is GGT. GGT normal. It's not liver. GGT elevated. Then we go down this pathway. So if it's the liver, then is this a hepatocyte problem or biliary? Okay, this is cholestasis. She does not have hepatitis. And is she sick or not very sick? Not too sick, right? She's no abdominal pain. She's not throwing up. She's coming to your clinic. And then any injury, is there evidence of damage? Well, her bilirubin's up. We don't know about that, but what's causing it? What's the next most appropriate management? Does she need a cholecystectomy, ERCP, liver biopsy, or observation? Out of those 4, what would you do next? We know we're not going to do a liver biopsy, right? And do they need either of these?
No, not yet.
What we would want to do next is what somebody already said. Ultrasound, but we didn't get that option.
Observation.
So it's observation. This person, this lady, when you go back and take her history, she was in the ED 3 weeks ago and got something for her urinary tract infection. She got Bactrim or Augmentin or something, and then she took it for 5 days, and then she's got cholestatic-related liver injury from her antibiotics. But you're right, I would probably get an ultrasound on her. Cholestatic injury, just to go over that one more time, usually if the cholestatic injury is severe, they're going to have pain. And if they have pain, it's almost always going to be extrahepatic, and it's going to be something in their duct, like a stone. They're also going to, and if they're sick, they're going to be vomiting, they're going to have fever, they're going to push on their abdomen, they're going to be tender, they could have cholangitis, they could have acute cholecystitis. And if there's no pain, then it still could be extrahepatic from like a pancreatic obstruction from a cancer, but it can also be intrahepatic. And then the etiology of the cholestatic injuries, again, medication, very, very common. It causes hepatitis and it causes cholestasis. And these are the questions that we want to ask in regard to trying to differentiate what's causing the cholestatic problem. So weight loss, elevated alk phos and Bili, what does it make you think of? Dilated duct.
Pancreatic.
So pancreatic cancer, okay? A female with pruritus, what is that? PBC, primary biliary cirrhosis. People with other autoimmune disorders, again, PBC. Somebody with a history of IBD, what is that? PSC, primary sclerosing. And then if they have other systemic problems like sarcoid or amyloid, of course, then you're thinking, well, maybe that's what they've got in their liver. So the differential for cholestatic liver disease is a little bit shorter than it is for hepatitis. And it's either drug-induced, it's a large duct problem, which you can differentiate when you get the ultrasound. It's either PSC or PBC, or it's some sort of infiltrated disorder inside the liver. So here are the 4 questions. Hello? Is there injury? Is there damage? What's the etiology? Hide. Yeah, I was going to do that. Liver injury. Liver disease will no longer hide from you guys. You'll be able to figure this out just real easily. You'll go through the question about, do I think it's a liver? Which organ in the liver? Is there any evidence of damage? And then you can go through the different etiologies and figure it out from there. And then one last question. What causes most liver injury? Always and forever think medication. Thank you. Any questions? Yeah, there's a list of medicines that cause liver injury to you. But again, I want to, if you guys are in your clinic, if you have any questions, just give us a buzz. We'll try and help you as best we can. Thank you all.
He tells me to hit